welcome to Accreditation TV, another episode. Today we're going to talk about business occupancies and ambulatory healthcare. And I'm happy to have two of our subject matter experts that should be no introduction required, but I'm going to introduce them anyway. So we've got Howard Nussman, who's been on many of these, as we've talked a lot about Accreditation 360 here in the last few months. And of course, Skip Smith, who's been on a few of them as well as one of our facilities experts, and happy to have both of you. Welcome today. Appreciate you giving us your time. Um, this kind of marks a little bit of a shift in what we're doing, in that we're going to keep doing these videos. We're excited about doing these videos. We're going to focus a little less on A360, although we're going to continue to talk about it because it's going to be certainly an evolving process throughout 2026 and probably 27 and beyond. But today we're going to tackle some very specific topics that seem to be points of confusion for a lot of people out there. That's why we chose this particular subject. I want to remind everybody, if you want to ask questions, please feel free to enter them in the chat. We'll be happy to answer those as we can. If we don't get to them during the broadcast, we'll definitely get to them later. We'll reach out to you. If you're one of our Accreditation Readiness Network members and you want to get CECs, you can get those through the platform. Let us know if you're interested in the ARN, and we'd be happy to set you up with that as well. So we're excited today to talk about business occupancies and ambulatory healthcare occupancies and the differences between those and what we typically think of in the hospital in terms of really the fire and life safety physical environment requirements. And I think it's a good idea for us to start at first and just kind of define ambulatory healthcare and business occupancies and how they differ from hospitals. So I'm going to start with you, Skip. If you want to take a stab at defining those for us.
Sure, and I just take it at a high level, and we're not going to get into nuts and bolts and everything like that. For clinicians and folks who work in ambulatory healthcare occupancies, it is essentially a hospital, and that's the way it should be treated. Your corridors are going to be a little bit smaller. They are going to be a minimum of 44 inches. There may be a grandfathering that'll allow them to go to 36, but however you've written your rules for conducting activities in your corridors, what you allow, how long you allow it to be there, and so on, is exactly what would be expected in an ambulatory setting. Business occupancy, on the other hand, is really a lot looser, would be the easy way to say it. You're going to be able to go down to the 36 inches, but there's things that they will allow in a business occupancy. For example, you can have a water cooler sitting out in a corridor as long as it doesn't go below that 36-inch minimum. So, from a standpoint of how they look and everything else, just remember that the ambulatory healthcare setting is much like the hospital. You also could have fire separations, smoke zones, things like that, that are not required in a business occupancy as well. And I think the other thing for clinicians, particularly to understand, is ambulatory healthcare occupancies are a defend-in place setting, where business occupancies are evacuation. So they're totally different in what they do. And which, this isn't during the building tour, but when the surveyors are looking at documentation, they want to make sure that your fire response plan addresses that. Do people know the difference between the two? And they can ask those questions as they're going along.
So I think what's important, I'm going to life safety geek out here for just a second and talk about the fact that what really triggers this is patients that are incapable of self-preservation, right? So if you've got folks in an ambulatory care
Mhm.
setting, let's just say outpatient surgery, because it's really easy for everyone to grasp. Once we start putting people to sleep or they're in a state of, pre-anesthesia, post-anesthesia, and they're the fire alarm goes off or there's some other type of emergency, they are dependent upon the staff for safety. That's what triggers that defend in place, and that's why ambulatory healthcare becomes more of a almost like a hospital with slightly lesser restrictions. But with a business occupancy where, you're primary care physicians or dermatology or whatever, where you're not doing, you can be doing basic, well, I say my friends like to say lumps and bumps procedures, but you're not doing anything that would cause a patient to be able to not be able to defend their own self, and get out on their own if there's an emergency. Then uh, there's much less restrictions and requirements, and you can have a business occupancy that is, in a strip mall or even a mobile home, or it really doesn't matter because the
Yeah.
patients take care of themselves. So
I have seen them in a mobile home.
yeah, I actually
Yeah.
yeah,
Yeah.
Yeah. I've seen them in
Yeah,
yeah.
residences.
like a
Yeah.
1960s vintage, house that now is a primary care office, for a primary care physician. Yeah, in some rural areas. Yeah.
So in
Um,
the trigger, and this is where from a clinical perspective, I think it's really important, we start talking about building the team of, the clinical, non-clinical teams in our hospitals and in our own team at MSL. It's like when you go out to that residence that's a business occupancy and you find out that, oh yeah, there's a new provider there that started doing, such and such, and it requires them to do, some
mhm,
kind of conscious sedation. That should set some red flags off for at least doing the due diligence to find out, should we reclassify this space? And if so, what does that actually mean from a
mhm.
built environment perspective?
Yeah. I notice in some organizations, what could be a real point of just confusion for staff is they may have business occupancy kinds of services being provided in a brand new building that they built, and they went ahead and outfitted it with all the requirements in case they did decide they want to do moderate sedation procedures, and in that space then begin converted into like an ambulatory healthcare occupancy, and so
That's very
it could be
common.
confusing. Yeah, and so it could be confusing for staff who are going out, say in the regulatory team, doing tracers and knowing, so when is it that I really have to be sure certain things are in place, sprinklers or whatever, versus not, because different range of buildings, but maybe they're all primary care practices. And they say, well, we got them over here. Why don't we have them over there? And if it's not required, it's a point where there needs to be a lot of good education, with the people who work in those spaces, but also with the regulatory team.
And that's the perfect segue to the next discussion point, really, which from the education perspective, when you talk about particularly fire and life safety response, the best way to do that is with fire drills and how we manage fire drills. Because the purpose of a fire drill, at least from my perspective, has always been to A, test the system, but B, provide the education and feedback to the most important part of the system, which is the staff and their response. Um, so, Skip, you want to talk a little bit about the fire drill requirements in ambulatory healthcare and business occupancies?
Okay. The let's start with the ambulatory healthcare occupancy. So, the minimum frequency for drills are 2 times per year. You have to do them per shift if they're working more than one shift. They are required to be live. So the drills in ambulatory are exactly like the drills at a hospital. The business occupancy, on the other hand, there really is no fixed minimum for when they're being done. However, best practice is they are done once per year, and those are documented as well, usually not by shift or so on. You can also do tabletops in a business occupancy, where in an ambulatory healthcare setting you cannot. Staff participation is required at the ambulatory setting, but it's only recommended in the business occupancy. You have to be able to address patient involvement when you're talking about ambulatory versus the business occupancy. So it's in short, the ambulatory healthcare setting is really the healthcare setting. It's the hospital, and you're doing essentially exactly the same. The with the business occupancy, it's essentially ensuring that staff know how to safely get out of the building, how to go to a place of refuge, and they know where that point of refuge is. And one of the things
Hmm.
that I see missed on fire drills for business occupancies is checking to make sure that there is somebody has traced the exit path or evacuation path to the rally point and documenting it. I would say, as a general rule, the fire drill critiques that are used in the hospital work very well for the healthcare or the ambulatory healthcare setting, but they do not transfer very well to the business occupancy.
Yeah, well, and one of the challenges with I agree with you is the business occupancies tend to be very unique. Well, not always. So we probably need to talk because a lot of like Howard touched upon the fact that sometimes there's business occupancies that look very similar to hospitals, and that's oftentimes because they're either a part of that structure or on
Hmm.
that
Hmm.
campus. We've been talking a lot about business occupancies as these kind of scattered weird entities, and you do have to treat those separately for sure. Like, and you've got these one-off, yeah, and residence or the mobile home or the strip mall, then the fire plan is going to be dramatically different from space to space to space. Therefore, uh, the fire drill evaluation needs to be dramatically different from space to space to space, as opposed to the kind of on campus,
Yeah.
more similar.
Yeah.
Does that make sense?
Hmm. Yeah.
So, from a clinical perspective, I think one of the challenges that we have um, is helping the staff understand when their role is defend in place versus when their role is evacuation. And Howard, I don't know, uh, from your perspective, what are some of the ways that we can improve that communication and understanding?
Uh, I think, and a lot of the confusion comes in that, many hospitals will have like a single day or 2 day, fair where they take people through all the required education. And when they talk about what do you do in case of a fire, they're giving usually the what do you do if you're in the hospital in the case of a fire,
Yeah.
and because that's the majority of the audience. And so they've got to be sure that that if they're talking about what do you do, that you're very clear about what's the difference between a business occupancy and how many of you work in a business occupancy instead of a healthcare occupancy. And just finding out, so when you do a drill, are people going around closing the doors or are
Yeah.
they getting out of the building? And you know, I think it's something that hospitals really need to look closely at, both in orientation, but also in their annual education. Who's the audience, and are we actually getting the correct information across?
Well, it's funny you mentioned that because I can recall several times being in business occupancies where, we're doing the event of a fire and you get, well, we race. Do you? You're gonna close the door, make it harder for people to get out? I mean, and it's, yeah, that was a little sarcastic, and I probably did say that at least once in real life, but, I mean, just, yeah, the point is
Hmm.
it's and I don't fault the staff for that misunderstanding. That's definitely a leadership issue, as you point out, and, part of the problem and one of the reasons, honestly, that we're doing all these videos and create this library for people to come back to when they're ready for it, it goes back to what you just said, like, 2 days of orientation. And at some point, all of that just becomes, like the teacher and peanuts, wah, 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 and you're just kind of missing the point. And I can certainly understand from a clinical perspective, there's a lot of things that they got to take into account. And probably the whole fire stuff gets, it's like, allow tune this out and reset my mind. Um, but so, any other I'm trying to think of what else we ought to talk about in terms of business and ambulatory healthcare differences, because there are a few.
Let me ask the experts, because I'm certainly not the life safety code expert. But in terms of fire drills, for me, of the places that I go off campus. Um, one of the places where it seems like fire is a huge issue or a prevention, issue is in the hyperbaric
Oh
area
yeah.
with wound care. And I never, and even though I assume usually I've got a life safety person or a physical environment person coming through that space. I mean, I quiz them about how often do you do a fire drill? What did you learn from the last one that you did? And so I don't know, Skip, if you want to speak a little bit to with that setting in particular,
Sure.
things that you look for.
Yeah. So, yeah, and it's pretty much similar to your experience. And the way I address it is, I will find the person who does it. Generally, there is an individual who has been identified to do the fire drills for hyperbaric chambers. I find that those folks are incredibly knowledgeable. They're very proud of the work that they're doing, and they love to tell you about how they go about it. So it's getting their procedures and having them shown to you. And I'll generally sit there with it open in my hand and go, "Walk me through this. How do you do this? What happens with it, and so on." And to your point about what do you learn from it, typically they can speak to that pretty well. But I want to expand that thought just a little bit, that the with the change in the new standards for the Joint Commission, or for Joint Commission, I guess, um, how's that data really being used? And there's times where the drill is done and it's put in a filing cabinet in a hyperbaric or in the clinic or in the business occupancy somewhere. And that data is never making its way back through the system to the safety committee, so that they're really looking at how effective are they. So it's just kind of following that piece of, how are they doing it? What are they finding? But then once you find it, what are you doing about that?
And is that not a role for whoever is sort of the leader over fire safety um, for the entire organization to be sure that they're using the proper tool when they evaluate their fire drills, that they're actually doing fire drills in the frequency required. So just sort of overseeing that and collecting that information to be sure that
Absolutely.
everything is in
Yeah, I think
place.
unequivocally that
Yeah.
there's
Yeah.
somebody that needs to be, and those will vary by title, and depending on how the organization is structured. But yeah, somebody needs to know that all of this is being done, and at the very least, ensuring that they're getting the right documentation so that they have data that they can take, and then the committees can really be kind of the evaluative body around what has been done and what suggestions need to take place from there.
Yeah, I mean, one of the things I see that I think is far too frequent, and I feel like I'm making excuses for my colleagues in the field, and don't mean to, but they're so focused on the hospital because that is the big job that they kind of
Mhm.
forget about what's going on outside of the hospital. And that's where that kind of data vacuum occurs. It's good intentions, not enough time, not enough report. Um, and that's something we can brainstorm. How can we help facilitate that? Because I agree that data is really, really important. And when you talk about hyperbaric, my red flags go up because that's a very high risk environment. And so is MRI. It's another very high risk environment, and there's certain things about those spaces that are very unique because of those risks. And part of what we want and expect the staff to know is what are those unique things, what are those unique risks, and what are the steps and controls and things that are there to mitigate the risk, that are provided for emergency conditions, and when is it appropriate and to trigger them, and when is it not appropriate, just particularly with MRI, but hyperbarics as well too. I mean, there's been some horrible things that happened in both of those
Mhm.
units
Yeah.
in the not so distant past. So
Yeah.
um,
So,
yeah, that's a good
so Steve, I think I would like to add another thing, and that is that there's been a lot of talk about the life safety surveyors now going to the clinics and to the ambulatory sites for sure, but going to some of these business occupancies. And I think that leaders need to be aware that it's a um, it's going to be a more thorough look at the environment. And one of the things that I think about are like the alcohol based hand rubs, the dispensers, how far apart are they? Are you managing them by the smoke zones? Things like that. You're going to see that kind of granularity coming from the life safety surveyors that you probably have not seen from the clinical surveyors in the past, because it's getting pretty specific when you get into
Yeah.
some of that stuff. Another one, Howard and I talked about
Is
this,
it?
or leading up to this presentation, and that is exit lights. And how many people are aware that you have to fully see an exit light from 100 feet? I think that, and in no way am I disparaging. I'm just saying this is more. You do it more frequently, and you're more accustomed to looking for some of this stuff. And so the big thing is overhead signage. And I rarely go through a hospital that has overhead signage and not find exit lights that are obstructed. So it's going to be that kind of more in depth observation of the exit corridors, things like that for compliance.
It's very much the similar to going from your primary
Yeah.
care physician to a
Yeah.
specialist, right? I mean, all of a sudden you've got someone that's looking very specific things that they've seen many times before, as opposed to more of a
Sure.
general look. And it's going to be interesting this year. I think there's going to be a lot of findings that come from ambulatory healthcare and business occupancy simply because of that increased level of surveillance.
Mhm, mhm. Yeah. And, so they're going to go to every place that administers anesthesia or moderate sedation. Um, they're going to go to every place that has any kind of behavioral health service, ambulatory. Um, you know, of the uh, primary care and multi-specialty clinics or whatever the business occupancy kinds of services. Um, they say that they will sample. If they have a small number, they'll go to everything. If it's not a small number, and they don't say what a small number is, so I think it means if the team doesn't think they can get to all of the sites, then they'll sample. But they will are guided to pick, like if there's large, medium, and small, to do at least one of each, and to include a small one as well as a large one in the sample. And I think sometimes it's the ones that are small that then you start seeing things like there's a corridor with a fire exit at the end of it. But since we don't use that door very often, let's just use that space to store things, and it becomes a storage, alcove instead of a way to get out of the building if they're in the case of a fire. Um, you know, but uh, I think that. There is a need for more people in the organization really understanding. So when do you have to have sprinklers? When do you have to have other kinds of fire safety assists? And when do you not?
Yeah.
Because,
Yeah.
you know,
Yeah, and,
uh,
and I think
it's
following
just a
on
challenge.
following on to that statement, it's like there's a lot of turnover in healthcare. We all know that. We see it in our city customers, that somebody's there one day and gone the next. And when it comes to the clinics, they have kind of been back of mind, and certainly the Joint Commission's bringing them forward. I think that really high performing organizations are not waiting for that twice a year fire drill. They're not just doing it on an annual basis in business occupancies. They're going out and they're really educating the folks that are there every day on exactly what to look for. And this is kind of where it goes back to what Howard asked about early on, or when you have to see of Howard, how do we get clinicians to understand it more? It's we need to do a better job of training it, and we need to train it through the eyes of the clinician. The clinician's vision is always on the patient. And we have to be better at explaining
Yep.
the environment how the environment helps them to be able to manage that patient and help them. And when the environment fails, that we've trained them on how to respond to it to protect their patient.
Yeah, and honestly, they see us as an intrusion whenever we're trying to convey these messages. I mean, I understand that. I mean, they're focused so hard on the patient that when we're out in the environment trying to train them on these things, we have to
Yeah.
overcome that.
Yeah, and
You know
and I
what
guess,
I mean?
it's happened fairly recently where I was at an organization and I was doing clinics primarily, and I had the opportunity to work with a clinic manager who was awesome. She could be a life safety specialist. She understood it. She knew what she was documenting. She knew why she was documenting it. She knew how everything needed to go. And yet I could go to another clinic that was maybe arguably a little bit further away. It was a new manager who was filling out the paperwork but didn't understand what the paperwork was.
Hmm.
Yeah, which is
Yeah.
really
Yeah.
bad.
Yeah.
Yeah. Right. Not that they're a really bad person for doing it. It's just they're missing the
No,
point. And
it's the failure of organizations having the luxury of time, if you will, to go back and do that. And so how do you build it in? This manager that I was talking about, most of her staff could speak to the life safety because that was a part of their daily huddle and everybody had a
yeah.
Hmm.
responsibility.
Well, it's the difference between check. um, we may have talked over each other there, Skip. I apologize. I was gonna say it's the difference between checkbox compliance and compliance with purpose. Really,
Hmm. Yeah.
it's
And I've seen in some organizations where they've had a very fast acquisition of a lot of physician practices, um, that they're acquired, and they have a manager who's always been the manager of that place, and so it's uh, 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 the orientation uh, hasn't been very good. So the person, she's just, or he's just doing what they have done as a private practice, in managing and making sure that the patients flow through. But now there are requirements because they're part of a Joint Commission accredited hospital and organization. And so the onboarding of the practice didn't include enough orientation and education about these new requirements. And so sometimes you'll find someone who promoted in from the hospital and they know way more about the regulatory requirements than somebody who has worked for 10 or 15 years in a physician practice that got acquired. And they just haven't had a chance to catch up to their colleagues in other parts of the organization as far as what they understand about, whether it's environment of care and physical environment requirements or clinical requirements or whatever.
yeah,
So it's a challenge.
yeah. So to kind of wrap this up, there's kind of both. It's the classifications are based on the the state of the patient more than the building, right? It's based on,
Mhm.
are they capable of taking care of themselves in the event of emergency? Are they not? If they're not, then that bumps us up into that ambulatory healthcare setting. And if they spend the night, I mean, that's really the only distinction between ambulatory healthcare and healthcare occupancy, which is what people traditionally think of as a hospital, is they spend the night. Um, so that's the main thing to keep into mind. And then, of course, because of those differences, how we train, what types of systems that are going to be in place and then have to be maintained are triggered. So, ambulatory healthcare, we're going to have more robust fire uh, evaluation, fire extinguishment systems, fire alarms, that sort of thing. They have to be maintained and tested. Business occupancies less, if anything. In most cases, business occupancies have exit signs without lights and fire extinguishers, and they just have to have clear pathways and an understanding of where to go. But in each one of those scenarios, how we train the staff, how we plan. Well, first, how we plan for a fire or other emergencies triggers is based on that particular place, that unique structure, and an environment, really, because the environment makes a difference too. If you're down here in North Carolina lately, all of a sudden ice is something we're concerned about for the first time ever. Um, but yeah, so the environment, the structure matter, and then that triggers how we do our fire drills. From a regulatory perspective, how often we do those drills and how we document those drills is driven by, really CMS and the life safety code. But we've already talked about, how often they need to be done. I think Skip made a really good point about, rather than resting on what's required, do what's necessary to ensure that people understand what their roles and responsibilities are. Yeah. So anything you guys want to add?
I can't think of anything else. I think we covered it pretty well.
Yeah, I did too.
Awesome. Well, I want to thank both of you, especially for wearing your blue NFL shirts. I prioritized warmth over brand today because it's kind of chilly. But anyway, I appreciate you guys being here and your expertise as always. Look forward to seeing you at the next video, the next episode of Accreditation TV. Again, feel free to ask us questions. We love to get those questions. Feel free to give us some recommendations for what you want to see in the future. And if you're a member and you want the CECs, let us know over there and we'll get them to you. So thanks again. Look forward to seeing you on the next one.